Good afternoon, everyone. Can you hear me?
Yes, we can.
Good afternoon, everyone. On behalf of the entire IISC community, I thank you for attending as an international speaker and a special guest, Kevin. Welcome to the 20 and 21 National Industrial Engineering Summit. Dear friend, it's our most important event on the year for IISC Mexico. Welcome, my friend.
Very glad to be here.
Good afternoon and welcome to the conference, Team-Based Risk-Adjusted Staffing During a Pandemic, an Agent-Based Approach. It's an honor to introduce and welcome Dr. Kevin Teff, who kindly accepted our invitation to share a bit of his knowledge and experience with us. To all our guests, we ask you to keep your microphones off, and in case of having any question, please write it in the meeting chat so it could be answered when the time comes. Before starting with the talk, we'd like to thank our sponsors, Allium Calidad y Productividad, Lean Six Sigma Internacional, Agile UPS, ADN Isaías, Make Makers, PMI Capítulo Puebla y Capítulo Profesional de ICE México for being a special part in this Cumbre Nacional de Ingeniería 2021. Our speaker for today, Dr. Kevin Teff, is the Harriet and Jerry Dempsey Professor and Chair in Industrial Engineering at the Clemson University. He has over 25 years of industry and academic experience, and his research interests include the application of simulation and optimization in healthcare, production, and transportation logistics. In particular, Dr. Teff studies healthcare logistic problems from patient flow to operating room scheduling to real-time healthcare decision-making. Without further ado, let's welcome Dr. Kevin Teff.
Thank you very much, Sergio. I appreciate the opportunity to speak to all of you today. It really is my honor, and I've known Luis for many years through our associations through IISE, and hopefully someday we'll get to visit in person in Mexico, or have some of you visit up in the US. So let me go ahead and Luis, I don't think that, or Sergio, I don't think I can, do I have sharing? Oh, I do, okay. Make sure I can do that. Just give me a second while I move things around so that I can. So do you see the slide now with the
We do.
title? Yes? Perfect. Okay, so this work is something that's been going on for, I guess now, since near the beginning of the pandemic. And it was initiated from our healthcare partner in our state in South Carolina called Prisma Health. And so we began early on working through this problem, and I'm going to explain some of that now. So the American Medical Association, and at one point it came out and said, we certainly had a workforce challenge pre-pandemic, but it's exacerbated by COVID-19. So there was already a shortage of healthcare workers before the pandemic, but this just really came to a major issue in all places around the world. And in particular, there were critical care physician shortages, and this is just showing by state in the US where the shortages were the greatest. you can find a lot of information and statistics online about just how much of a shortage there has been over the last few years. And so this pandemic it really is limiting the ability of physicians to provide that level of care that they want to, but not even because of the initial a shortage of physicians prior to the pandemic, but the health of those physicians during the pandemic. So now we have to deal with what happens if there is infection, what happens if we lose additional physicians that have to be cared for or go into isolation. So initially our project was to look at just the anesthesiologists. So that was the group we were working with at the beginning. And how could we minimize the number of anesthesiologists that were unavailable to work? If we could put some policies in place, then this could provide some protection and supplement the additional policies that were already in place throughout the healthcare systems. So in phase one, we basically were going to create a model for this situation. So they were dealing with this in real time. And the way that they would staff across their facilities, because this is not just a single hospital, but Prisma Health has several facilities where they have anesthesiologists. And a typical schedule would move those anesthesiologists from facility to facility. And this is desirable from a quality of work life. They enjoy that movement and getting to see different environments, and it just keeps them, I guess, in a way fresh, that they enjoy that interaction. But you can imagine during any kind of pandemic or infectious spread, that can be exactly the opposite of what you want to do. So one of the key questions was, how much infection or spread would there be under several different policies? So we began with 6 facilities, and these are the anesthesiologists' requirements that they have within each of those facilities. So the facility 1 is their main hospital with 21 anesthesiologists. And we did break those into 3 groups. Let's see here. Is somebody saying that the screen wasn't advancing? Is everything okay? Just let me know. Right now I've got a screen up that you should be able to, oh, I see now. You guys aren't seeing the same screen that I'm sharing. I'm sorry about that. Let's see, let me go ahead and change that. All right, I'm going to stop sharing and I'm going to reshare now so that I can make sure I've got the right one here for you. Sorry for that. Yeah, you're all probably wondering then, I've got all this information I'm trying to share with you, but you don't see the numbers on the screen. So Okay. All right, so as I was describing this facility, the health system has 6 facilities, and the largest one being facility 1 that has 21 anesthesiologists. You can see the 21 are broken into 3 groups of 7 anesthesiologists each. And then in facilities 2, 3, and 4, they have 6 anesthesiologists broken into 2 groups of 3 each. And then facilities 5 and 6 are the smallest. So we use this as the starting point. For this model that we're going to build, we basically built an agent-based simulation model. And so what we wanted to do as best we could is represent the transmission, the interaction of the anesthesiologists among their peers, and how many contacts would they have with other anesthesiologists, and then the disease itself. How long would the incubation period be? What would be the likelihood of asymptomatic conditions, so that because if we have the anesthesiologist in the system infecting others before they know and before they were tested, then we're going to have that spread. So we can do that inside of an agent-based model and track the infections. Of course, once an infection would be found, we would quarantine that individual and they would sit out for 14 days. And so you see each one of these parameters are elements of our simulation model that we built for representing the system. The immunity period, we did two types of tests. One where, because this is also phase 1. This was vaccination. So think back to 2020, and what would the hospital have done, the health system? And that's another reason, because this doesn't have to just be for COVID-19. This could be for any future pandemic. How do you best handle these situations? So we had all these different parameters, and some of these that we tested at a couple different levels. Okay. So again, as I said, we used an agent-based approach, and where inside this model, the agents are the anesthesiologists, the people, as well as the hospitals. So the hospitals exist as agents in the model. They have characteristics. And so if you're familiar with some simulation, you may understand those terms. But simulation is one of my favorite subjects to do research in and also to teach. So each anesthesiologist is connected to a hospital, like I described before on that listing of facilities. We put the anesthesiologists into a specific hospital. And then their location or shift where they would work would be updated every week. And so the way that the model begins is that you can either have an initial infection coming from the patient or from an anesthesiologist. As soon as we start the model, we could assume there was one anesthesiologist already infected. So you have different options on where to place an infection. And the model results were based on a 90-day simulated time frame. And we ran this for 500 replications. So as in simulation, we need to run things more than just 1 time or 5 times or 10 times. It really depends on how variable the output results are. So we need to replicate that result in a sufficient number of times so that we have confidence in the number that comes out in the end. This is just a screenshot of the simulation model that was built, and it's the again phase 1 version that you would that we had. And I guess what I would like to point out here is it's what we call a state chart for agent-based simulation. And so, you know, everybody could start as being in this susceptible category for whatever hospital that the anesthesiologist is working in. And so think of this as a flow for these anesthesiologists. And they will stay in this yellow box of being susceptible, but they're going about their job. And they're having contacts with some physicians. They're having contacts with patients, right? And they will stay in the yellow box, assuming that they don't get exposed. So once they're exposed, they will come in through, you know, and that's basically from a physician or a patient transmission to this next category. And then there's an incubation period before anybody knows that that anesthesiologist is infected. So that's the danger period, right? If that can be, so we have to be aware of how long that period is. And if once the individual is infected, if it's asymptotic, this length of time is going to be problematic, right? Because if we have that same anesthesiologist working with other anesthesiologists, those other anesthesiologists will now be susceptible to infection from just being in close contact with that one infected anesthesiologist. And so then you get the infection detected, and you go into a quarantine period. And after quarantine is over, you're either recovered, or in a small amount of people, you would die. And of course, this is a model, so you could, depending on the infectivity and the virality of the disease, you can change those parameters and numbers. And then recovered, now you can either go back into the system or never, or be immune and never go back into the system again. So these are the things that we're working with in coming up with scenarios to run. Okay, so I wanted to go slowly through the background and how we build up to the scenarios. And I'm going to have a number of results we're going to go through. I'll probably go through those a little faster, but because I think the more important part is for you to understand, how do you model something like this? So the 3 levels of staffing that they wanted to test were inter-hospital mixing, the baseline. This is what the anesthesiologists enjoy doing. This is how they want to work. They can work in any facility, and they can, one anesthesiologist can work from one facility to the next, or switch groups within a facility. Remember, I said in the big facilities, there's more than one group. For a given week, they stay in the same group though, for a given week. Intergroup mixing is that, as it says, an anesthesiologist can work in any of the groups within a single facility, but they won't go to the other facilities. And then no mixing is that they stay in a specific group and don't mix at all. So this is a graphic to show how this looks. And you can see the 6 facilities, and facility 1 having the 3 groups, facilities 2, 3, and 4 having 2 groups, and how that just a visual of how that works. And we had 4 cases that we wanted to test in this phase 1 approach. And basically, once infected, they'd be immune for 90 days with no patient transmission of 0. So basically, that means in case 1, we're only looking at the infection among anesthesiologists and their ability to infect each other. And then once they had it, and then they would be immune for the rest of the time period. In case 2, again, there's no patient transmission. So it's only the anesthesiologists infecting each other, but they're immune only for 14 days and could be infected again. For cases 3 and 4, we introduce a patient transmission rate. So now you have to deal with both of the patient transmission as well as the anesthesiologist. And one of the things the reason we were testing it on the anesthesiologists is when they're around patients, yes, there is the chance that they will get infected by the patient, but they're very careful in how they approach and interact with the patient. But what happens is when they leave the operating room and maybe interact with another anesthesiologist, they may not be as careful. And so there's opportunities there for possible transmission. So that was one reason why we wanted to specifically talk about the anesthesiologist transmissions. Okay, so here are some initial results. And when we looked at having 3 anesthesiologists infected at the beginning, and all in facility 1. So those 3 groups in facility 1, each one of those groups would have an infected anesthesiologist. And then we looked at those 4 cases that I described for the differences in how many anesthesiologists or how many were infected on average, the total over the time period of the 90 days, and the average number not working. So out of this total, so the total number was 41 anesthesiologists. So on average, how many weren't working? So we can see for these 3 cases, inter-hospital mixing versus intergroup mixing versus no mixing, the changes in these values. So if I look here for the inter-hospital mixing, the number not working was anywhere between 3 and almost 7. And for no mixing, it was around 2 to 5.5. And this was based on some mortality numbers here as well. We compared those. I don't really need to, I think, spend too much time because, again, one of the challenges with these models is it's hard to know what the transmission rate is. So we tried our best and ran with a few different options for what that transmission rate could be. Graphically, this really helps, I think, to understand what it looks like over the 90 days. And so if you look at this graph, at the beginning, we start with 3 anesthesiologists that were infected, okay? And for these, we're plotting 6 different options, okay? All of them were for case 2 and case 4, okay? If you remember back here, case 2 and 4 were the 2 situations where we had immunity only for 14 days. So they go back to work, only be immune for 14 days, and then possibly infection, could be infected again. And so case 2 had no patient transmission, and case 4 did have patient transmission. So all of the case 2 ones here are the purple, blue, and orange. Those are the bottom 3. Okay, and then the red and the black and the green are the top 3. So because those have patient transmission in them, there's more activity, more anesthesiologists not able to work on average. And it also goes, as you would expect, the top line is for the inter-hospital mixing. The black one is just the intergroup mixing. And then the green, the bottom of the 3, is for no mixing. And so I think these are important for us to see because it really gives us a sense of how the disease spreads and forces people not to work. Okay. So we have several of these results, not all of which I'm going to go through in detail, especially I want to go on to the phase 2 part anyway. But you know, here we only put 1 anesthesiologist as infected, as opposed to 3. And we tried some options of if that 1 anesthesiologist is infected at facility 1, which is a larger facility, versus at 2, 3, or 4, which are smaller facilities. And the changes from these were not great, not much different. Clearly, so one of the things we wanted to look at was comparing, if we start with 3 anesthesiologists infected and have different transmission rates. So if the physician of this anesthesiologist transmission rate is doubled, what is the difference in the number of infected and the number not working? So when that rate doubles, I'm just going to look here for intra-hospital mixing. The number not working across these 4, you can see here from 3 up to 7, that was the base case. Then here we're up to close to 6 to 9 across the 4 cases. So that's giving us some interesting information. And then this is the graphic, the plotting of those 2 scenarios. Okay. And the last phase 1 test that we ran was what if there would be testing every week, versus testing every other week. Okay, so in the testing every week, the average number of anesthesiologists not working, that 3 to 7, goes up to 5 to 8. And it doesn't, maybe that doesn't seem like a lot, but remember that we only have 41 anesthesiologists in total, okay? It's not that we have 1,000 anesthesiologists, we only have 40. So our population is small. All right, so to address that about the population, we went to a phase 2. And in phase 2, we wanted to add in other workers that associate with the anesthesiologist. And so we added 2 new agents for some operating room interactions. This would have been the CRNAs and the circulating nurses. The CRNA is a certified registered nurse anesthetist. So this is the person who assists the anesthesiologist, but really cares for the patient's a treatment of anesthesia throughout the course of the surgery. And then we have the circulating nurse who runs, keeps things moving and has kind of command of the flow inside of the operating room along with the surgeon. So we're going to call these all of the agents, we'll call them healthcare workers. So on these slides, you're going to see HCW. That's going to be our term for healthcare worker. And again, look at some updated results, taking into account these new healthcare workers. We're also going to consider the fact that now this work was done this year, and we've added some information about vaccination, and that immediately we can remove people out of that population of being infectious. So, so first we begin with a result on again the 3 total healthcare workers infected at initialization, all in facility 1. Nobody vaccinated, but no patient transmission. And so, and for all of these, I've kind of totaled up all the facilities to kind of say, all right, what's our total average number infected, and average number not working. So here in the inter-hospital mixing, we're up at 32 and 20, close to 22. For no mixing, you're at 16 and close to 11. Okay. You know, the intergroup and no mixing look very similar here, but it just depends on the case and the conditions that we're setting. So in this example, instead of having all 3 infected at the 1 hospital, now what we've said is, well, what if we have 1 infected at location 1 at that hospital, 1 at location 2, and 1 at location 3, and in different groups. So now as they mix in the groups within their hospital, they're spreading the disease. And so that's why this result is going to change from the prior one. And the other reason why now, when we look at this second slide, that with no mixing, our numbers go way down, but it's due to the size of facility 1, of location 1. There are so many people at risk in facility 1 that it's all driven by that number, and they all are susceptible because we have an infected person in every one of the groups in the main facility. Okay. We then tried a couple of other options. Nobody infected at the beginning, but there's a patient transmission that is at play, and we looked at the results with that case. And you know, because in all likelihood, so we can have the anesthesiologists and all the healthcare workers tested prior to them starting the week. And so we could avoid having them in an infected state at the start. But in reality, we probably can't avoid patient transmission altogether. So this could maybe be considered a more realistic scenario. And then how that compares with a 50% vaccinated group with the same patient transmission. Okay. So, you know, the numbers are roughly half, but not exactly 50%. The last result is to show what if there are, you know, no healthcare workers initially infected, non-vaccinated, and then the patient transmission is varied. So instead of it always being the same at every facility, and this is really what we're doing right now. This is current research. We're still trying some things out to learn what it is that we can track so that we can set and better policies and make changes to those policies as we see things develop. So it's likely that certain facilities will have a higher transmission rate based on the kinds of patients that they are admitting or where they're going to try to keep people for a particular, keeping people, the patients isolated. Like in COVID, certain hospitals are dedicated to taking care of those types of patients. So the rates can be different. And this particular example was trying to address that. Okay. Let's see. So obviously protecting the healthcare workers during a pandemic is critical. And if we can find ways to segregate the populations of workers so that they don't infect each other, then that's going to be a huge improvement in the ability to provide healthcare and deliver healthcare delivery to all the patients. So we can significantly reduce the number of workers that would be unavailable to work by as much as 60%. I do want to make it clear, though, it may seem obvious to just say, keep everybody segregated and just don't let anybody mix. But there's a quality to the way that they work, and some people don't want to be forced to work particularly in one location, either for the quality of just their job, interacting with other people, or that they find certain facilities less desirable. So there are costs associated with those things. And I think part of what we want to do is capture that in our future models and to understand what's the risk of infection compared to the benefit provided to the healthcare worker by allowing them to move from one facility to the next. So we're looking at a number of things as well, and looking at models that we can develop, a stochastic model to capture the dependence between the risk of infection and staffing and scheduling decisions, and how do we put in the right amount of staff to prepare and predict when there might be a surge, and right to ultimately allocate folks to mitigate that infection risk. I'd just like to thank the Harriet and Jerry Dempsey Professorship that I have here at Clemson University, as well as Prisma Health. They funded this small seed grant for doing some of this work, and the folks in the Department of Anesthesiology for their support as well. My last person I want to thank, who is among the several hundred people watching right now, is Vishnu. So Vishnu Girisham Prabhu is my PhD student who has come a long way at Clemson over the past several years, started as a master's student and did some creative inquiry research with me, which is just kind of exploratory research. And that turned into the beginning of doing some basic level research with me, both during his master's and his PhD. So he's done a lot of different project work, and this is basically just kind of describing what he's been up to. And he is hopefully going to be finishing in the spring, in May of 2022. The other thing I wanted to, sorry, let me get this one up here in a second. I'll go through this really quickly so that we have time for some questions at the end. Does that work, Sergio? Okay. So I did want to spend a few minutes talking about the graduate program opportunities just at Clemson University for both master's and PhD programs. And I've actually been the graduate coordinator for many years, did that for quite a while. I'm not doing that now. I'm actually now the department chair here at Clemson for our industrial engineering program. But I've been here at Clemson for a long time and really have loved the years that I've spent here. It's been a great blend of it's a great location, as well as the people that I get to work with every day are fantastic. This is just a little shot of our building on campus and some of the working space that our graduate students will occupy in the building. Our program is fairly big by US standards, that we have about 600 undergraduate students. Our graduate population is about 130 students, and we have 20 tenure track faculty members now, which is amazing. We've had a significant amount of growth in the last few years, and it's really allowing us to explore more areas of research and get students involved in a wide variety of applications. We're a highly collaborative bunch here, and we focus our strengths of optimization and human factors. And those areas of strengths are applied in topics such as healthcare, like I was showing here, supply chains, transportation, human-computer interaction, and social applications, many different things. In particular, these are just little snippets, I'll call them snippets of where faculty have expertise. So we have a lot of folks that have expertise in supply chain and transportation systems. And you can see that listing here for certain faculty members and what areas they have expertise in. And then healthcare systems, and a number of us over there too. This doesn't mean that this is the only thing that faculty member does, but it is an area where they have that expertise. As well, human-computer interaction, renewable energy, and societal applications in industrial engineering. So really, really interesting topics. I don't want you to look through all this list. It's a lot of information here just to show that we collaborate with each other as faculty. And in particular, the one that I'm highlighting here is what I just talked about today. And so there were multiple faculty and students that were involved with this work that I was describing. Lots of different areas of methodological strengths. And then where do we apply those strengths? So I already kind of talked about some of that. We have active chapters of IISE, HFES, which is Human Factors and Ergonomics, and Informs. And you know, while I love all of them, of course, my IISE is certainly something of a passion of mine for the time that I've spent both as a faculty advisor of students here at Clemson, as well as being a leader for the region and then for all the regions most recently. And that's how I got to know Luis from Chapter 666. Yeah, so that's about all. I'll just kind of flash a couple pictures that we've got faculty that donated some pictures to me to share. And you just kind of get a little glimpse of what campus looks like, as well as some of the surrounding nature and areas around us. I love seeing pictures from other places, and so perhaps this is something that's interesting to you to see what it might look like in another area of the world. But I must say, there's some people who are some pretty talented photographers in taking some beautiful pictures like this. So that is where I'm going to stop for my presentation. And I will stop sharing my screen here.
Thank you so much, Dr. Tev, for this interesting conference. We have learned a lot. And now we will pass to take the questions and comments from the attendees. So I will ask all the participants if you can please write all your questions in the group chat. And in the meantime, we also have some questions. That is, how did the pandemic affect your job?
How did the pandemic affect my job?
Yeah.
Not specific to this.
No,
project.
in general.
Yeah. You know, I'm sure that many of you had, you know, struggled with the same situation. But we obviously had to do a lot of online teaching, and so for the rest of 2020, then in the fall of 2020, last fall, we were able to do some hybrid teaching. So some of our classes went into the classroom, but with very limited capacity. And but you know, I think what ended up happening through this is we learned a lot about technology and how to do things and be effective at getting more people involved in an online environment. I still love teaching in person, and I think a lot of us still like being in a classroom in person. But it was, I think we are now more, it's easier for us to pivot to something where we can share a lecture online, do something as a live stream, or record a lecture and let the students watch it later. If there's a conflict or something comes up. So I think it's making us more flexible, but it was hard.
Yes, I can agree with that. We also have another question, that is, where can we find all this information? Can you share us like a website or something like that?
So I think, you know, I'd be glad to share the presentation with the group. I can send it with the leaders, and you can decide how to distribute that. I can also send a couple of web links for more information about either the research or Clemson to the leaders as well.
Thank you so much. And at the end, if you could provide us like any, I don't know, any email, any contact, just in case someone wants to get in touch with you.
Say that again, Melissa. What would you like me to do?
Any email or any form of communication that we can get in contact with you, well, the participants.
Yes, here, I'm going to do that right now. Yes, you can definitely reach me at that email address. I'd be glad to take your inquiries. Yeah, I was really enjoyed being able to talk to you and explain to you some things about Clemson Industrial Engineering, as well as all of the modeling, especially modeling and simulation and agent-based modeling. Those are things that I definitely enjoy.
Thank you. We also have a question from Nora. She says, thanks for sharing your time and knowledge with us, Mr. Tev. I'm curious about the work done during the pandemic. mainly due to the human factor. How much does any strategic model differ from the practice when it's actually applied to people, patients, or clients who are not used to the way that the staff works?
So thanks, Nora. I appreciate that. So whenever we build a model and we show results of a model, you might see this as well if you've done some projects, done work like that. It doesn't just translate into something that you can implement in the real world, because you have to consider, you know, what else will they need to do to make a change to a policy, to the way they staff. And the people in the system need to understand and trust the results that come out of a model. So you have to make sure that they can trust the results. But I think you can't assume that the way you've modeled it you'll immediately be able to implement that in practice. What I like to say is we often do studies that provide decision support for the decision maker, for the person who's in the system and looking at what you're telling them. And then they can say, okay, well, you're telling me that I should put in a no mixing plan, right? I should have no mixing of my anesthesiologists. Well, instead of that, I know that I have this employee who provides expertise at these two locations, and I need that person to go to both. Well, that's a condition that we didn't plan for in the model. So the person who's making the decision in the real system knows things that we don't. And we have to, that person will use what we were able to tell them, but then implement it in a way that makes sense.
Thank you so much. Leonardo asks, any recommendation that you give us as young engineers?
Oh boy, good questions, because there's so many things, right? That, you know, I think the one key thing is to stay inquisitive. So keep learning and don't ever feel like you know everything, because we are always learning. I'm always learning, and I mean, you know, we learn from each other. So you know, be prepared in what you're working on, and be thorough. So do the work thoroughly, but then still, when you go into a meeting or a presentation, know that you're usually presenting to somebody who has expert knowledge about how something works. So you need to keep learning from that person and make sure that what you're doing reflects that.
And our last question is, how important do you think the human factor, since we are working from a distance, is it important when talking about business?
So I'm not sure that I understand the question.
I think he is asking like how important is like the human contact now that we're talking about business, that we're working from the distance, I think.
Mm-hmm. So let me say, when we work from a distance, we still have human interactions on how we conduct business. So we still need to deal with that part of professional work. And, you know, in service businesses where you don't maybe interact face-to-face as much, your human component is still how do you communicate the information? So are you doing it in a way that the person who gets the information understands it all? So there's still a human factors component in the way information is delivered and received. And so as an industrial engineer, we want to design systems that make that information usable and easy to comprehend. So when we deliver systems and things like that, we always make sure that the user interfaces are designed well. I don't know if that completely answers the question being asked, but that's at least one thing I would say.
Yes, thank you so much. And now we'll pass to take a group photo. I don't know if you can all please turn on your cameras and smile for the picture.
There's all those faces.
Okay, smile, please. Give me 1 second. There's a lot of you. Thank you so much, Dr. Tiff, for answering all our questions and all the conference. We're so grateful for your time and participation. Now we will be given a reading of your recognition delivered by ICE Región 13, thanking the commitment you have with the next generation of engineers. ICE México Región 13 grants this recognition to Dr. Kevin Teff for his participation as a speaker at the team-based risk-adjusted staffing during a pandemic and agent-based approach conference that took place on October 6, 2021 within the framework of the National Industrial Engineering Summit.
Thank you very much. I really appreciate it. And I look forward to the chance to maybe meet some of you in person someday, whether it's here at Clemson or if I make a visit down to Mexico and see some of your universities. So.
Yes, of course, we are so looking forward to it. Thank you so much. And without further ado, I wish you all farewell and an excellent rest of your day. And I invite you to join us to our next conference at 4 p.m. and all our future conference and workshops. Thank you so much.
Thank you.
Thank you. Have a nice day.